So we are live now.
Good evening, delegates. Good evening, participants, and good evening to faculties member. Thank you for joining Shield Connect. And today we are back with our series Tuesday Tea Time. Learn simply with Dr. Kawita Bapat ma'am. So before we start with this session, let me introduce our coordinator, Dr. Richa Narkade. Ma'am is gynecologist and obstetrician. So I will hand over the session to Dr. Richa ma'am. She will introduce our guest and Dr. Kawita ma'am. So I hand over the session to Dr. Richa ma'am. Thank you, ma'am.
Thank you, Nishant and the team Shield. So I welcome you all in our fourth volume of Tuesday Tea Time with Dr. Kawita Bapat. And today we are having guest Dr. Jyoti Karande. She is Secretary Indore Obs-Gynae Society and member of Foxy Quiz Committee, Joint Secretary of AICOG 22, and she's member of many she's a member of IFS, IMS, and ISAR. And ma'am, I'm handing this session to you now.
Thank you, dear Richa. Good evening, everyone. Greetings from Indore Society. I'm Secretary of Indore OB/GYN Society and bring greetings from Indore Society for a very happy Holi. It's my immense pleasure and I feel very proud to introduce our own Kawita Bapat Madam. We have seen her immense and monumentous journey from being Secretary and President of Indore Society. And then she was part of the Governing Council of ICOG, past President of Indore Menopause Society. She became member of ISAR, IAGE, and then she was elected as the chairperson of Breast Committee. And under her guidance, we had BreastCon in Indore. She has made vaginal surgeries very famous. She was a member of the Executive Member of Vaginal Surgery Committee of MP, and then she has made vaginal surgery as part of all workshops all over India. She was Joint Secretary. She was Secretary for AICOG, and under her guidance, Indore was so fortunate to conduct the AICOG. She conducts courses of vaginal surgery for ICOG and also for other academic courses. She is writing books. She has written many chapters in many books. And also now she is author of many books. And she has brought best out of us. Many of Indore members will say that whenever they are in a problem, Madam will rush for their help, be it a PPH or any other medical emergency or any surgical complication. One phone to Bapat Madam and she will run for our help. And she was Vice President of Foxy. We were part of her campaign as Vice President, and each and every member of Indore Society felt that it was their own fight. And now ma'am is running a presidential candidature and we wish her best of luck. We all will join you for your campaign and will do everything possible to see that you are future president of Foxy. I welcome you, ma'am. This series of Learn Simply is very useful for all new budding gynecologists and obstetricians. Just in a few minutes, we can learn so many things, small algorithms which help us in day-to-day our profession. Whenever we see a patient with similar problems, it flashes like, yes, this is what we learned in that class. And now this is the patient. This is how I need to treat her. Welcome you, ma'am, for this new series of breathlessness in pregnancy.
Thank you. Thank you so much. Without wasting time, allow me to share my screen. And I'm sharing my screen. And today's topic is basically the acute shortness of breath. The problem, as we have discussed, that is learned simply in only 30 minutes. So we have not reproducing the topic that we are going to have this topic or like that. It's a simple thing. So it's a 31-year-old, 34 weeks, presented to hospital, shortness of the breath and the backache. She had a shortness of breath over the last 1 to 2 months, unimproved by the course of azithromycin. Upon arrival, she complained of the worsening of the shortness of the breath, inability to lie supine. During history, endorsed difficulty swallowing pills and a persistent dry cough. She had no interval improvement despite antibiotics and presumed upper respiratory infection. Her past medical history was remarkable. Vital signs included temperature normal, heart rate 109, blood pressure normal, respiratory rate normal, 96% oxygen saturation on the room air. Physical examination revealed a gravid uterus with respiratory distress, unable to lie supine, absent breath sounds in her left chest, and she had a palpable supraclavicular lymph nodes. Per abdomen, 32 weeks, soft, non-tender uterus, normal extremities, fetal heart racing in CTG normal, without contractions. Ultrasound revealed breech presentation, electrocardiogram confirmed only sinus tachycardia, but other imaging performed demonstrating a large heterogeneous anterior mediastinal mass with internal cystic changes versus necrosis and multiple enhancing left pleural nodules. Mass extended superiorly to the right paratracheal area and mass affect the trachea, right thyroid lobe, left mainstream bronchus and lung bronchi. A large left pleural effusion, near collapse of the left lung. Heart was shifted to right with a moderate pericardial effusion. Left main pulmonary artery was compressed by the mass, and there is no evidence of pulmonary embolism. Admitted for labor and delivery. So this type of case with acute shortness of the breath can come to us, and we should be able to differential diagnosis with other things also. Same with another 30 years patient in emergency department, shortness of breath, has a pulmonary embolism. Why we are saying pulmonary embolism? Dyspnea, pleuritic chest pain, hemoptysis, and maybe all the features of the history. Symptoms can be absent. Collapse, central chest pain indicate massive pulmonary embolism. Blood tests include arterial blood gas, classically shows respiratory alkalosis, but may be normal with small pulmonary embolisms. Treatment, if she comes right in a time and we are able to treat her, low molecular weight heparin administered immediately, and all pregnant patients with a suspected venous thrombosis, and until the diagnosis excluded, very, very important, anticoagulation is strongly contraindicated. And patient hypoxic tachycardia admitted for administration, observation should be followed regularly antenatal. I'm just putting these two scenarios. If some mass is there, and this is a case of, but now we are simply talking about how acute shortness of the breath comes, what are the risk factors, what are the differential diagnosis, how to treat, how to go for the algorithm and do it. Acute onset of shortness breath, dyspnea, pleuritic chest pain, cough, hemoptysis. It can come on examination, low-grade fever, tachypnea, tachycardia, diminished oxygen saturation, diminished breath sounds, audible crackles, and evidence of pleural effusion and pulmonary examination. Laboratory tests reveal acidosis, elevated A/A gradient on the ABG analysis. On AKG, evidence of right. I'm not talking, this discussion is cannot correlated with the previously two cases which I have talked about. So it's a general discussion when the patient of acute shortness of the breath comes to us. Evidence of right heart strain is a pattern with or without right XDC deviation and T-wave inversion. X-ray chest may be normal, show evidence of multiple peripheral wedge-shaped area of consolidation, pulmonary edema or pulmonary effusion. However, if ABG reveals arterial PO2 is more than 80, diagnosis of pulmonary embolism is highly unlikely. So we are talking about the differential diagnosis also. It's very, very important. Measurement of D-dimer level in pregnancy is generally unhelpful in making the diagnosis of pulmonary embolism. Okay, PE. Then how to differentiate? You have to differentiate many more things when the patient of the acute shortness of the breath comes. Pulmonary embolism, amniotic fluid embolism. She may be having pneumonia, including aspiration pneumonitis, Mendelssohn syndrome, pneumothorax, congestive cardiac failure, pericarditis, pulmonary edema. And sometimes venous air embolism, very rare, associate with the ruptured uterus, placenta previa, and persistent arterial septal defect. So acute shortness of the breath, we have to differentiate between all those conditions. Eclampsia is also one of it. Drug overdose or a withdrawal is also reason. Sometimes a rib fracture, a patient come with a trauma or something, and she can have the acute shortness of the breath. Then amniotic fluid embolism is an obstetric emergency, and 80 to 90% maternal and perinatal mortality. It accounts 10% of the maternal death also, and A is seen most common during labor and delivery and immediate postpartum period. Now, there are few risk factors when the patient comes with acute shortness of the breath. is number one, cesarean delivery, if there is a chorioamnitis, multiparity, preeclampsia, prolonged labor, fetal demise, amniotomy, intrauterine pressure catheter, intrauterine saline injection in cases of abortions, placental abruption. So this list is basically, they give the risk factors for having the acute shortness of the breath, and we have to differentiate it right from pulmonary embolism to all the conditions. Now, how to characterized by normally acute onset of dyspnea, hypotension, hypoxia, and prodromal symptoms may include sudden chills, sweating, anxiety. These are the problems. Then physical examination may reveal acute onset of the respiratory distress. There may be a cyanosis, hypotension, tachycardia, hypoxemia, and neurological manifestations. Sometimes the seizures and the coma the patient can come with. And a hemorrhage. Hemorrhage is always, we should click in a mind. And DIC is usually acute and severe, leading to acute shortness of the breath. So acute shortness of the breath is maybe a presentation of any other conditions or any other thing. So whenever there is acute shortness of breath, we should be worried about. Then amniotic fluid embolism is a clinical diagnosis. X-ray chest versus scan is a little value in acute setting. Components of amniotic fluid, fetal spermas, and mucin may be identified in the medullary vasculature at postpartum, but this is not pathognomic, so it's no use to us. There is a primary supportive cardiovascular support should be optimized. This includes maintaining oxygen saturation more than 90% for any case of acute shortness of the breath. Then arterial PO2 must be more than 60 millimeters of mercury, and then systolic blood pressure more than 90. Urine output more than 25, and ionotropic support, dopamine and a mechanical ventilation should be considered. If needed, then treat the bronchospasm, terbutaline, aminophylline, steroids as needed, and CPR and a cardiopulmonary bypass may be required if the patient is of acute shortness of the breath. DIC is a typically predominant clinical feature of amniotic fluid embolism, and serial CBC coagulation studies should be followed. Aggressive blood product replacement is initiated, and avoid heparin in established cases of DIC. So, and the fetus is at risk of hypoxic ischemic cerebral injury. IUFD can occur. Urgent delivery may be necessary regardless of the gestational age. Regional anesthesia is contraindicated in acute setting. General endotracheal anesthesia may be needed for cesarean. So, acute shortness of the breath. So, this is the algorithm when the patient comes to us. Take the concise focus history and perform a physical examination. CBC coagulation tests are there. ABG arterial blood gas and chest X-ray should be done. And we have to find out the oxygen saturation of that. If the patient is hemodynamically stable, if no, call a code, immediately anesthesia consultation, oxygen supplementation, place 2 large bore IVs, consider central hemodynamic monitoring, gestational and fetal well-being, and treat likely the cause. Consider empiric anticoagulation if pulmonary embolism is suspected. So make it a point. If patient is hemodynamically not stable, think of pulmonary embolism, treat it. But if the patient is this hemodynamically stable, the initial state management, oxygen supplementation, gestational age and vital being we should find out. Place 2 large bore IVs, and we should do the serial IVG, EKG, X-ray chest. And subsequent management, consider the cardiology consultation. Then trans-esophageal echocardiography is also important to find out some big mass or anything is there. Antenatal steroids, if indicated, considers MFM and neonatology consultation also there. Further management depends on the diagnosis. See, we should be able to diagnose. If there is a pulmonary embolism and pulmonary edema, I will tell you what to do. If there is a pneumonia, supportive care, broad spectrum antibiotics, sputum culture to identify the organism, and narrow antibiotics, consider blood culture. Eclampsia is there. And if there is amniotic fluid embolism is in my diagnosis, supportive care, urgent anesthesia consultation, ionotropic support, consider early intubation and mechanical ventilation, aggressive management of, and consider urgent delivery once the mother is stable. Now I will talk about the pulmonary embolism and edema in this thing. If there is a pulmonary embolism, related pulmonary embolism, risk stratification, HD status, RB size, biomarkers, fetal status. Then 3 tests are there. If it's high risk, intermediate risk, and the low risk. If it is high risk, cautious IV filling with adrenergic support, anticoagulation, IV, and then hemodynamic and obstetric surveillance, and we need a multidisciplinary approach. If intermediate risk, anticoagulation with IV UFH, this are the low molecular weight heparin, short-term hemodynamic, and obstetrical surveillance. If low risk, still anticoagulation with low molecular weight, hyperweight system. And if the patient goes on clinical deterioration, we have to worry about this. And if it's improving, still we'll continue the anticoagulation. Now, antepartum, IV thrombolysis at first, depending on the local expertise. Embolectomy or thrombolytic lysis, ECMO is also very, very important. Peripartum, high bleeding risk, consider ECMO, surgery, embolectomy, thrombectomy if available, or the thrombolysis with the preparation of major bleeding. Late postpartum, IV thrombolysis at first line, depending on local expertise, surgery, embolectomy, thromboblectomy, and ECMO is important. Now, this is for this, and if there is a pulmonary edema, activate the emergency response, call for help, skilled assistance. Number 1 is airway, clear the obstruction, upright position, administer oxygen. Breathing, assess respiratory rate, oxygen saturation, temperature, X-ray chest, arterial blood gas. Auscultate chest, consider non-invasive, invasive ventilation. If circulation, minimize aortocaval compression. Maternal, by BP, heart rate, rhythm and ECG and fluid balance. Fetal, heart rate and gestation. Intravenous assess, full blood examination. Assess renal function, assess liver functions, assess coagulation and cardiac enzyme. And transthoracic echocardiography, continuous monitoring. Hypertension, the treatment will be different and normal is the different. If there is hypertension, yes, we should control the hypertensive. Consider causes, administer drug, preeclampsia, endocrine disorder, illicit drug intake, intravenous fluid and other, and administer nitroglycerin, furosemide, morphine, magnesium sulfate, calcium crystal antagonist. If she is a normotensive, consider cardiac diseases, sepsis, tocolysis, amniotic fluid embolism, aspiration, IV fluids and other. Drugs to be administered, furosemide, vasodilator, inotropic support and mechanical support. And both are there, then stabilize pain, save birth and transfer to the intensive care environment. So thank you so much for the patient listening and thank you so much for being with me today. So it's a 30 minutes, as I promised. The discussion is just still we are doing it in a faster manner. So thank you so much for being with me. And I like Dr. Jyoti and Dr. Jyoti Banglawan and Jyoti Karande are there. They can talk few things about.
Madam, excellent talk and very crisply you covered acute shortness of breath. What I feel is, as you said very rightly, interdisciplinary care is very important. We cannot handle this emergency on our own. We need to call help very urgently. Physician, respiratory physician, ICU in charge, whoever, we have to call immediately and manage this condition. Secondly, most of the time patients or relatives are very scared of imaging. If it is required, chest X-ray, CT, MRI, or everything has to be done to save the life of mother. Nothing is going to harm the baby. The people, they know how to manage. They will shield the abdomen and do whatever is essential, but just it will harm the baby. So many patients deny doing essential imaging investigations which are required for saving life of mother. So this should be reinforced that it is not dangerous to do any test which is in benefit of the mother, and we should go for it. Fetal harms are very less documented, and with proper precaution, it can be done.
Thank you so much. Actually, the acute shortness of the breath, it's not that common condition. But when it comes, when we have gone through all the algorithms, we should be able to do the things. Like in a pulmonary edema, all ABCD, we know about it. When we talk about the pulmonary embolism, as early as the anticoagulant therapies should be started. And when we talk about the amniotic fluid embolism, we are worried what to do, how to call the anesthetist and how the ventilation should be started. And sometimes we are just having the acute shortness of the breath as 2 cases, which I have talked about earlier. There was a big mediastinal mass over there and everything was normal. That was compressing her and making her acute shortness of the breath. And this otherwise pneumonia, sepsis, there are many other things also. So we should be able to differentiate that the acute shortness of breath is due to what reason. And there is a big list, but very easy. If we have gone through the right algorithm, we will be able to see. So thank you so much for being with me. And I like Dr. Jyoti Banglawala is also there. So we will just any other question which you feel, Jyoti, we can.
No, madam, you covered. Thank you very much. You covered it very nicely. Just a few points. So previously, as a house doctor, we used to do respiratory rate, pulse, and BP count by ourselves only. We don't rely on anybody when the patient is admitted or patient is coming to us. So this is the basic thing to do by every gynecologist, and to be vigilant is the very, it is very necessary to be vigilant. Otherwise, at the last moment we are helpless to take the help of other fraternity. We have to ourselves see the patient. Yes, it is the shortness of breath, and we have to visualize what is the reason, and then we can seek for the help. Otherwise, there is a 3-4 major things for the reasons for the acute shortness of breath, and if we are confused, then how can we ask for the help for a particular fraternity?
Yeah, absolutely.
Yes,
Absolutely.
even our staff should know that acute
Yeah.
shortness of breath is not a warning sign. It is a red flag symptom.
Yes.
Correct.
Allah
Call
Machao and
code.
call
It's a
everyone.
call code. It's
Yes,
a call
yes.
code.
It's not a warning sign that you keep on observing. It is
No.
a very fast acting scenario.
In one
Correct.
case,
So we have all, in a last, sorry.
in one case,
Yeah.
I found when the patient complained of the shortness of breath, the sister and the nursing staff was giving the pillow, the pile of pillows was there, and when I arrived at the ward, the patient,
Embolism.
I lost that patient actually.
Yes, yes,
So
right.
it's a really important to diagnose in that the first time, and the thing should be in our mind. Like for example, last week I just talked about thyroid storm, though it's a very unusual condition, but at least I had 10-15 phones from the fraternity that it was a good to know that the thyroid storm is also one of the bad condition. So though we are discussing a little different conditions, but they are very important. If we know the matter, we can treat it. It's not a theoretical thing, but it's a very practical.
It will come once in a life, but you have to save that one patient.
We are very
I
thankful,
appreciate
madam.
Dr. Jyoti's point of discussion that we should be able to diagnose as early as possible, and we should know him in the back of our mind.
Actually, when
And,
you,
with
you
Dr.
are taking the
Jyoti
topics, madam, you are taking these type of topics. So in the back of mind, everybody should know कि
Yes.
हाँ, हो सकता है.
कुछ तो
And
जा-
thank
yes,
you very
yes.
much for enlightening this, because these are very rare topics, and everybody they means they are not having the chance to encounter such patients. But you,
Yes.
when you listen or you learn from someone so senior like you, then the back of mind we should know. Shortness of breath, ye ho sakta hai. Thank you very much, madam, for this.
Thank you so much. I think we are right in time, Nishit.
We are
Nishant,
right on
we are
time,
right in
ma'am.
time.
We are having 5 more minutes. If
I think you next time you just ask people to ask questions into the chat box so that you can read it also. Anna, thank you so much. Be with me next Tuesday tea time with some new topic. Only 30 minutes. I don't want this much introduction also. It's okay, but
Happy Holi, ma'am. Happy Holi to
and more
everybody.
cases, and happy Holi.